Slides are at the front always, so it's okay if people join us a little bit late. We'll keep on time. Uh, so here are my objectives, but I'm not going to waste time talking about them. You're just going to have to trust that we're going to get to all of this, and we can come back around and talk about them a little bit more at the end. Here are my disclosures. There's nothing that I'm going to talk about today that poses any conflict with anything else that I do. I was originally supposed to give this talk back, I think, in June, and then for a variety of reasons, it just kept getting pushed back and back and back. But we're going to talk about kind of the future and the path forward in safety within our department. And kind of the best way to do that is to look at where we've been, not just in our department, but in safety kind of in general. And in looking back, this picture actually is of me that was 30 years to the day when I was originally supposed to present this talk. You can see back there that these are old telemetry monitors, what they used to look like 30 years ago. I realized that there are some students that we're working with now that weren't even born yet. Had bigger glasses, and Moffat stole what was left of my hair, quite obviously. It's just kind of interesting to think back. A couple months ago, when I was at the IHI meeting, they had kind of a group of us who've been doing patient safety, and they wanted to know kind of everyone's backstory, what got people interested in it. So it got me thinking about really where I started thinking about patient safety. And it actually started with this book called Safety at the Sharp End by Rona Flynn. And I bought it off Amazon. It was one of the books that was recommended for you. And I don't know what I could have possibly been reading that made this book pop up as a recommendation, very different from anything that I was looking at up until then. It talked about non-technical skills in fields typically outside of medicine, where it talked about air traffic control, submarines, firefighting, which firefighting is really interesting. There are probably more parallels between firefighting and anesthesia than there are between aviation anesthesia. The same with air traffic control. Probably more parallels between aviation traffic control and anesthesia than there are flying the plane. But in reading this book, kind of it dawned on me that a lot of the problems that we face in anesthesia, and I saw a lot of parallels between some of the problems that we deal with here, are being dealt with by different techniques used in other industries, and that there's probably some application between what they do and what we can do. The book that I bought on the way home was this, Understanding Patient Safety, Bob Walker's first book. I actually bought it at a Borders to tell you how long ago that was. Uh, for those of you who don't know what a Borders is, it's like a Barnes& and Noble, but it doesn't exist anymore. And that kind of brought me on the path. I became the department's first patient safety officer. In fact, the first patient safety officer of any department at Moffitt. And, I really don't have too many disillusions about how that started. I think a lot of my initial role was that I would answer the safety reports and take them off the plate, and keeping other people from having to read through them and answer them and get them turned into risk management on time. And that kind of evolved, that role evolved over time, not just here at Moffitt, but kind of nationwide, where people started talking about what should a patient safety officer within a department do? What can they do? And kind of the interesting thing is in trying to describe it, we couldn't really find any good references on it or any papers on it. So Dr. Patel and I actually wrote about it. What an anesthesia patient safety officer is, what that role looks like, what they can do for not just a department, but for a hospital. This concept has evolved over time. It's a paper that I was published in 2021 that I still get questions on. In fact, I'm going to meet with someone from New York at 11 to kind of actually talk about this because he's interested in setting up a program like this at his own institution. I was asked to repeat this with a couple of colleagues in an issue in the ASA Monitor a couple months ago, patient safety, the role that a patient safety officer can do within a department that then can apply to the hospital in general. What's kind of neat is after this, it did kind of take off in that it was cited as one of the 100 Years of Progress papers documented in anesthesia and analgesia, and that the American Society of Anesthesiologists picked up on this in their statement on safety culture, that really that an anesthesiologist should be appointed as a dedicated patient safety officer within a department. This is kind of an ideal goal. And I think it's kind of neat that here at Moffitt, we were kind of at the forefront of this. And it turns out that there are many differences between quality and safety. There's a lot of quality work that's been going on for a long time, and we conflate safety with it quite often. We think quality and safety, they kind of go together. And they do. They're very related, but they're not the same. Just because someone is a black belt or green belt or yellow belt and they understand play and do study act cycles and they can draw control charts and run charts and things like that doesn't mean that they understand the nuances of systems thinking, psychological safety, how a just culture works, and how accidents happen. So it's not that the same person can't do both, it's that there's a separate set of skills between both, and that if you're making sure that one person is doing either one or the other, you need to make sure that they know the right skills and that the skills fit the job that they're doing. When we look kind of at a department, not just a department, but rather a hospital or health system as a whole, you can see that 100% of problems are known to frontline employees. There's no surprise. Those of us who work on the front lines, we know the equipment that doesn't work, we know the process that doesn't work because we live it every day. Only 4% fill up to the top managers. This is something that's often cited. I don't know that there's strong science behind it. In fact, I'm willing to bet that there's not, but it just kind of makes sense. Now, it's not to say that the people who run Moffitt need to understand if our equipment works or not, because clearly they have so many things to think about. They can't possibly know everything in every single pocket. But what needs to happen is that these are the people who kind of sit in this middle management between the frontline employees and the top managers. These are the people who deal with the majority of safety work in any organization. And they need to understand how safety works and how to solve these problems, because these are going to be the people to do it, not these people up here. And that kind of brings up an interesting point because CMS just released a patient safety structural measure that will affect hospitals, pretty much every hospital nationwide. Moffitt is not excluded from this, and that they're looking at implementing this in 2025, so just a couple of months, making sure that everyone in an organization understands safety and has training in safety. Moffitt's still kind of working out the details in that and how we're going to do that. But one of the things that we put together is kind of a training program for these middle managers, that these are the people who get the safety reports, that they know how to read safety reports, how to review an event, and how to design a solution that's going to work. Because there's kind of this, again, this big gap between these many different types of work. So it starts off as work is imagined. That's how these people kind of at the top here imagine the work is being done on the front lines. Then there's work is done. That's how all of us who are working the front lines actually do the work. And then there are a couple of other things that lie in between. So there's kind of this work as imagined concept. And then we describe that to people. We prescribe it. And this to the people who actually do the work. So there's how we manage we do it, how we imagine we do it, how we tell other people to do it, how the people actually do it, and how these people, when asked how they do the work, how they describe the work as being done. This is a bit nuanced, but there are many differences between these. So there's a huge gap between how we imagine the work being done, how we tell other people to do it, how those people say that they do it, and how they actually do it. And that's why it's important to have safety officers in departments, because these are the people who actually know how the work is being done. They don't rely on the policy manual to tell us how other people are doing it, but they know actually how it's being done on the front line. Now, if we look at the evolution of safety, this is, again, Bob Wachters' first book, his book, third edition, that came out 10 years later. You can see it's more than 3 times as big. It's now 6 years later. If he was going to come out with another book, which I don't think that he will, it would be even bigger. It's an evolving science, just like anesthesia. Just because you knew it once doesn't mean that you'll know it for the rest of your life. You have to keep up because things change. The publications in safety, you can see, remain pretty much the same since the 1900s until the publication of To Err Is Human, which we'll talk more about in a second, in 2000, and then it kind of took off. This is just midway through 2024, but it's going to end up on par with where it's been in the past. Now, if we look at where safety kind of began, and certainly there are papers that have existed long before this one came out. This is the Harvard Medical Practice Study, which looked at adverse events and negligence in hospitalized patients. It came out in 1991. Combined with a practice study that occurred in Colorado and Utah, it led To Err Is Human, which is the Institute of Medicine, which is now the National Academy of Medicine, probably their most famous report, saying that the amount of deaths caused by medical error is somewhere between 44,000 and 98,000 a year. The equivalent, and this was picked up in editorials and newspaper clippings that at the time that talked about it's the equivalent of a jumbo jet crashing every day. And that's kind of important because when we talk about one death occurring at one hospital, one death occurring at a hospital maybe 200 miles away, it's kind of hard to quantify. But when we think about a plane crashing, we think a lot of deaths occurring all at once at the same time. We pay attention to it. If a plane were to crash 2 days in a row, it would definitely be on the front page of every internet site. Everyone would be talking about it. If three planes crashed 3 days in a row, the FAA would ground all flights and we'd stop and figure out what is going on before we allow flights to take off again. We consider it unacceptable. But in healthcare, we're having essentially that equivalent every single day, and we weren't doing much about it. So when this paper came out, this report came out, it actually started the renaissance in patient safety, where a lot of things changed very quickly. We saw checklists, we saw huddles, we saw all sorts of things occurring. And then this book came out in 2020, a couple years ago, that talked about still not safe, which is why we haven't made as much improvement as they have in other high-risk fields, including healthcare. I'm sorry, outside of healthcare, including aviation, things like that. Just going to ask you to look at your phone and mute your mic if it's not muted, please. Thanks. But still not safe basically began to change the tide. Like, why aren't we making as much improvement as we have in the past? Then this paper came out just last year, and this is by David Bates and colleagues. And what he did is he took the Harvard Medical Practice Study from 1991 and he replicated it and said, okay, we're 32 years later. Where have we been? What have we done? Are things getting better, or are they or staying about the same? And what he found is that they're staying very tragically the same. So after 32 years, we're still seeing an unacceptably high rate of adverse events and medical errors compared to what we were looking at before. We have a long way to go. Now, that isn't to say that we haven't made some improvements. We've made pockets of improvements, but healthcare has changed. We're doing new things. We're taking care of sicker people. People are living longer. They have more complications. They're more actively involved in their care. They have preferences and requests that we need to honor. There's a lot that's changed, and essentially all these changes together haven't yielded this large improvement that we should have seen by now. And along with this came several books that came out. Like this one on the left, Mission Improbable. This is using fantasy documents to tame disaster. So basically, this talks about how industries, we come up with policies and procedures that have no chance of working. No chance of working. They address a problem, but we can't use any of it. Kind of one of the biggest things like this that I see here on a daily basis, every time I walk by those stair chairs that are meant to evacuate patients who are non-ambulatory down the stairs in the event of a fire on a unit. I mean, if you think that we can strap every non-ambulatory patient on the 5th floor to one of these stair chairs and evacuate them down several flights of stairs while people are evacuating on the floors below them, each one at a time, it's just not going to work. I don't see how that could possibly ever happen, especially with sick patients, obese patients. But we have them anyway. And this kind of, again, points to the use that we have this fantasy solution, which is going to address how we're going to evacuate people downstairs, which just has really no chance of actually working. We had this huge amount of rules that come into play. Back in that picture that I showed you at the beginning, I remember on the unit, they had a policy binder that they'd refer to. By the time I was a medical student resident, it now became several policy binders. And now we have an online searchable policy library. The number of policies that Moffitt currently has on there is in excess of 700. So 700 policies and procedures. There's no way that everyone working could possibly know everything that is in the policy or procedure that relates to their daily work. But yet we have them. Paper safe is the triumph of bureaucracy and safety management, along with the tyranny of metrics and how we measure things. We'll talk more about that in a little bit. And then Playing by the Rules, which is a really neat book that talks about how our obsession with safety is putting patients at risk. And a lot of this talk comes back to targeting this notion of zero harm. Zero harm is an aspirational goal. It certainly needs to remain an aspirational goal because there's never going to be a set number of which it is acceptable to harm. With that being said, we need to realize that there is no way that we cannot harm anyone ever. And just because a patient is harmed doesn't mean that we need to give up and throw everything away that we're doing and change everything radically, because chances are it works most of the time. We need to understand the nuances of why it doesn't work. And this kind of pulls into to view the concept of safety too. So safety one is learning just from things that go wrong, We need to learn from things that go every day. So if something wrong happens one in 1,000 times, we need to also learn from the 999 times when things go right and understand what nuances make that one harm event different before, again, we throw out everything and try and change everything and make it new to avoid that one episode of harm. Things that we've relied on over the years, like incident reporting, checklists, root cause analysis, the Swiss cheese model, just culture, the British Medical Journal on Quality and Safety uh, released a series several years ago, and every couple months they target another one of these and they talk about the problem with them. You see, the co-editor on the series is Ken Catchpole, who was our visiting professor last year. But it talks about a lot of these things were adapted from industry, from aviation, where things are very stable, and then immediately applied to healthcare, which is it's a complex adaptive system where we can't use the same techniques and get the same outcomes that we can when we're talking about a factory line or assembly line. So a lot of these things just don't seem to work as well. And this kind of brings up this quote from H.L. Mencken, now over 100 years old. There's always a well-known solution to every human problem, neat, plausible, and wrong. A lot of things that we assume are going to work just don't. And to that point, there's kind of a hierarchy of intervention effectiveness of things that work, telling people to be more careful. We do this all the time. We coach and counsel people. We say, be more vigilant, pay closer attention. If only it would work like that. Educational programs, sitting people down, talking to them about patient safety, kind of like this morning, passing more rules, policies, and procedures, giving checklists, adding boxes to checklists here, whereas designing systems, standardization and protocols, building in redundancies and fail-safes, these are the most effective, but they're the hardest to implement. Now, with that being said, this range that exists here, it's not to say that educational programs are wrong. In fact, if you're doing something new, if you're learning a new technique using a new piece of equipment, educational programs are a key and essential component to it. But you can't just rely on them. You have to do educational programs around a system that is designed so that people have success. And that kind of also is used oftentimes to assign blame when something happens. And this is from Amy Edmondson's book, The Right Kind of Wrong. And I'm a huge fan of Amy Edmondson, but I'll admit that I'm definitely not a fan of this because it looks at things that are praiseworthy, experimentation, uncertainty. This is when you're designing something new. Things that are blameworthy, sabotage. And I think that we'd all agree on that obviously sabotage is blameworthy. But sitting right above that is this, inattention. So if your attention inadvertently deviates away from specifications, I really don't think that's one step away from sabotage when looking at blame. Let me give you an example. So imagine that you're providing anesthesia in an operating room, and hopefully this isn't a stretch for any of you on the call. You're setting up the case. The nurse hands you this bag and says, I think this is for you. The patient name is crossed out, but it's a drug that you're familiar with at a dose that you're familiar with. It has a rate to be hung at. It has all the bud, dates, times, signatures. Everything's good. It matches the patient. You hang it. Surgeon walks in the room and says, hey, where's my TXA? I'm ready to inject it into the joint. It's at that point that when you look at the bag and you see this, that it says intra-articular. In fact, the only difference between this bag and the intravenous bag, everything else is going to be the same, is this route. It says intravenous instead of intra-articular. So when you made this mistake, you were definitely primed for it. You were set up for it. You were given an IV bag that has a rate on it, a drug that you're familiar with, an appropriate dose, and it looked the same as the bag that you received last week that went intravenously. So what happens when an event like this occurs? And I picked something that's kind of a low harm event. There's really not much harm in giving intra-articular TXA intravenously. If the patient were particularly sensitive to TXA, obviously intra-articular route would result in a less likely chance of having a hypersensitivity reaction, but it isn't going to be catastrophic. So when this event occurred, and we talked to the person who made the error, and this was in fact an error because something happened that was not in what was intended. The question that they asked is, how did you find out? Because the person who made the error didn't report the error. And in fact, in looking at this, this error was made before by another individual a couple months earlier. So, and that event wasn't reported either. If we truly had a just culture where people felt that they were not going to get blamed and that the importance was on learning instead of making errors and being embarrassed and things like that, the right thing to do for the people involved would be to say, hey, I did it. And I told you so that we could solve this together and prevent this from happening again. When we talk to other people about it, because you do the substitution test and find out could other people make this mistake too, the first question that people ask, and this has been the first question for the past decade, whenever we talk about an event, someone always wants to know who did it. And the bottom line is that it truly doesn't matter. If this can happen to any one of us, it can happen to every one of us. Are all capable of making errors. We all have made errors. In fact, humans make between 40 and 60 errors a day, which is to say that they do something that is not what is intended. To believe that people stop making errors the minute that they cross into the hospital and take care of patients makes no sense. It just doesn't work that way. And then finally, when this made its way through safety reviews, some of the comments we got, not from people in the department, but from outside, is that, hey, they didn't follow the 5 rights of medication administration. And I'm sure if you've looked at this, there are 5 rights. There are also 8 rights, 10 rights, 12 rights, and I think we're up to 14 rights. It just becomes incredibly insane. Moffitt, in its policy, actually uses 8 rights, which I cannot remember. I can barely remember the 5 rights, which is right patient, right medication, right dose, right route, right time. I certainly can't remember the 3 more after that that Moffitt states, or that they weren't paying attention, they weren't being vigilant. And I want to point out that the 5 rights is, and it's been called this, destination without a map. We all want to achieve the 5 rights, but you can't punish someone for not following the 5 rights. You need to design a system in which the 5 rights can be achieved. The same with vigilance. You can't beat someone into being more vigilant. You can't tell them to pay closer attention next time. It doesn't work like that. Vigilance, which is essentially nothing more than sustained attention, we're all paying attention, right? All of us, as long as we're conscious, we're paying attention. We're paying attention to one thing or another. The question is, were you paying attention to the right thing at the right time? And again, you can't tell someone to do this. A couple colleagues who are smarter than me help write this. We were talking about vigilance and anesthesia practice and essentially what it is. There are some people who are naturally more vigilant than others, and we know that based now on 100 years of science. Rewarding or punishing someone based on it doesn't make sense. I mean, again, you can't tell someone just pay closer attention next time, and they're like, oh, okay, and we'll do it. What we need to do and what vigilance is based on designing a system so that you are designed to pay attention to the things that matter most at the time that they do. And then also teamwork. Teamwork has been shown to support vigilance, especially when members of the team are tired. If they're tired together and they know each other and they've worked together before, actually the team performs much better than a fresh team that has never worked together before. So a lot of this has to do with designing the system so that it comes together so that people pay attention. It's a meme by Drake. I like Drake. Who doesn't, right? This comes from software, and software is actually a little bit more advanced in some aspects than we are in healthcare. Accidents are almost never the fault of a single person who clearly saw what was going to happen and then ran toward it or failed to act to prevent it. And we need to keep this in mind. There's still too much blame in healthcare. And honestly, one of the biggest sources of blame is from a colleague. And that's kind of changed over time. It used to be from the bosses who would fire you, and a lot of it comes from colleagues. They kind of side eye each other. They don't trust each other. They think that, the other person is just lazy. They're not as smart. They're not as attentive. And really, none of that is the case. So when we look at kind of a just culture, when we assign, culpability for these events, it exists along the gradient. And exists on one side, the slips, lapses, and mistakes. And again, these are the errors that we continuously make, that we do all the time. And then as we add increasing individual culpability, we end up on the opposite spectrum, which is knowledge and intent. This is Dr. Death or The Good Nurse. So any of these medical, true life medical horror stories, I mean, these are knowledge or intent, showing up at work under the influence, purposefully harming patients. Again, that exists on one spectrum. On the other are, again, the slips, lapses, and mistakes we all make. And at some point, we need to draw the line where we kind of make this kind of transition to when does it become more about the person and less about the system? a couple things that I'll say, even when you're here with the good nurse and Dr. Death and these stories that exist over here, the system is not completely off the hook because the system has allowed these things to continue to occur. If you hear the story of Dr. Christopher Dungy, he moved from hospital to hospital to hospital as he was under investigation at each of them and was allowed to continue doing what he was doing over an impressive number of years at an impressive number of facilities. So this doesn't completely absolve the system of having some responsibility for not allowing um, people who are, again, under the influence or set on causing harm from continuing to do it. Just like here, the person is not completely absolved from this. Again, we all make mistakes, we make slips and lapses, but if you're having a lot of trouble and you're making a lot of mistakes and slips and lapses, a standard deviation or two from your colleagues, then maybe this work environment is not the appropriate fit for you. So drawing this line, kind of where we make this transition, becomes a little bit difficult and a little bit challenging. Um, it's a book that I really like. Organizations feel a high need to assure the work that is being done by the workers is the work that is represented in the organization's formal work control documents. So making sure that there's a policy that covers everything and everyone is following the policy. If the worker would simply follow the process, nothing bad will happen, nothing bad could happen. And then the authors, state this idea is crap. They make their idea on it unambiguously clear. And I just love books like this that come right out and say it. We can't hold people to rules hard and fast all the time, and we cannot have a rule that covers everything. There are, in fact, goal conflicts. A couple years ago, I presented at the ASA, and we were talking about um, what are the metrics that anesthesia personnel have most readily accessible to them that they're held most accountable for. And across the globe, and there's no exception here, it's first case on time starts. Every day you get a report if your cases were started on time. And then when you look at what patients care about, it turns out that that's the least thing. As a patient, you don't care if you're 2 minutes late or 5 minutes late. You want to survive the surgery. Um, you want to not be nauseous. You want to have your pain controlled. So when we measure people on things that don't matter as much as other things, this is what happens. We work in a volatile, uncertain, complex, ambiguous environment that exists. Again, you'll never do the same case twice. You may do the same type of operation, but the patients are going to be different. They have different physiologic reserves. They have different things going on with them. It's quite different every time we do it. We have the local rationality principle, which is people do reasonable things given their goals, knowledge, understanding of a situation, and their focus of attention at any particular moment. So again, what makes sense at the time that the event occurred, in hindsight, may not make sense to you when you have the ability to sit in a chair and think about what happened. But that's not how the events present themselves to the people involved at the time. And then we really need to do is best navigate this just culture with the assumption of good intent, that everyone comes to work to do the right thing at the right time. So after, like I said, about a decade of doing this or more, I've kind of changed the things that I read because you get kind of disillusioned with hearing the same thing over and over again and seeing that we're still making as many errors as we did 30 years ago. So we look at organizational culture. There's probably no such thing, it turns out, as safety culture, which is really interesting. Safety culture is really a manifestation of organizational culture on safety. How to build communities within our department. In small groups. So this is asset-based community development, which is a really neat idea, which says that we rely on the hospital and the larger structure for some guidance and some help, but we cultivate what we do best within our department. No one knows best about safety, efficiency, and quality in anesthesia as anesthesiologists. So we train people that we have in our department to understand these things rather than rely on people without kind of the knowledge of the daily work and the work as done to tell us about it. How to form teams, which is interesting because there's a lot of things out there that say teamwork in anesthesia and surgery lead to better patient outcomes. The problem is you can never have the same teams. This is kind of a pie in the sky. It doesn't always happen that way. So can you form teams on the fly with different people that have really good outcomes? And guess what? Pilots do it all the time. If you look at the Miracle on the Hudson, the pilot and co-pilot met for the first time 3 days before. So it's kind of knowing the individual role you play, and how to work together with someone who you may not have worked together very often before to achieve the same outcomes and same good processes that occur. And then building a community within an organization. One of the great books that I read talks about empowerment leadership by Frances Frei and Anne Morris. Um, and she talks about kind of the layers here. The model behind this is empowering others as a result of your presence so that even in your absence, the empowerment continues. It talks about trust, love, belonging, and strategy. Trust, love, and belonging occurring in the presence of the leader, and strategy and culture existing in their absence. And we're going to end today's talk looking at love, just because I'm feeling a little nostalgic for the department. And maybe we'll get to the others at some time in the future. But to get there, we'll start with trust. And the book does have a couple hokey moments in it, honestly. But if you just kind of push through, you understand where they're getting. To trust somebody, if I want you to trust me, you need to feel that you are seeing the authentic side of me, meaning that I'm not being two-faced. You need to believe that I have sound reasoning and judgment. Doesn't mean that you need to agree with me, but you need to understand how I got to the answer that I did. And then finally, you need to believe that I care about you and your success. So it's this authenticity, logic, and empathy. These are the three things that make up trust. And again, like I said, it's a little bit hokey, but when you think about people who you don't trust or you don't have much faith in, you realize that it's one or more of these things that they're kind of missing when you interact with them. Now, to get to love, which is the second step, you kind of go through this kind of pathway. So it talks about standards and devotion. So if you have high devotion for somebody but low standards, you kind of end up here in the fidelity side, where you kind of let them slide with a lot of things. Kind of the best way that I could think about this is years ago, my wife and I had one of her relatives do some work around our house, lay some pavers in our patio, and he did, not the best job. And this is kind of here, we had deep devotion. It's a family member, but accepted low standards. So we end up here in fidelity. That's not really a good place where you want to be. A lot of times with coworkers, and especially in safety and quality, when things go wrong, we kind of keep this high standards but low devotion. We treat them with severity. And again, you don't want to be here because it just doesn't work. It doesn't work long term. Neglect is when you neither really care about someone and you don't really hold them to any standards. And if you have someone like that on your team, you really need to let them go because you're not doing them any favors. And then if you're the boss of the team or leader of the team and you kind of treat everyone with, you don't really care if they come or go, and you don't really hold them to accountable to anything. Really, if you're the team leader, you need to step down because you're doing a disservice to the entire team. What you really want to do is get to this right upper corner of justice, where you treat people with high devotion and while holding them to high standards. And with that, we kind of end up at this. This is how we get to devotion to high standards. Not the last time that you'll see this, but it's probably the first. What we have is on the right side, we have the just culture algorithm that Moffat follows. This is Mark's just culture algorithm. We implemented this in 2019. On the left side is the Vanderbilt professionalism pyramid. And Vanderbilt has done a lot of research on this. They've been using it for a long time. Our department got a wellness grant, and Dr. Mahill, Melissa, Brandon, Catherine, and I went out there for 24 hours. It was a real quick trip, but 24 hours to learn how to apply it. And then what we have sitting in the middle is the Moffat policy, the Moffat specific policy, which addresses employment. So kind of how the professionalism pyramid, because I know that we've talked about the just culture algorithm in the past, how the professionalism pyramid works is basically if there's a single concern. So let's say someone thinks that you're rude to them, they're upset with you. They think that something that occurred that is a professional slight. That is brought to your attention by a peer. It's not punitive. There's no investigation. There's no questioning what happened. You'll never figure out exactly what happened. It's a situation of which there are always two sides. So it's brought to you by a colleague, and it's just brought to your attention. Like, hey, this is how you were perceived. And that's it. They call it a cup of coffee talk because it should take less time to have the talk than it should to have a cup of coffee. So it's just 2 minutes or less. Just again, a concern that's brought to your attention. No need to get defensive, no need to explain. It's just brought to your attention. A lot of times this is all that's necessary. Like sometimes, none of us are having a great day every day. Sometimes we're short with people, we're rude, and we don't mean it to be. It just comes across that way. So if someone just tapped you on the shoulder and said, hey, you came off kind of harsh, you can self-correct your behavior. If that continues again, and it continues several times, it then becomes an apparent pattern. And the apparent pattern is something, again, that separates you from your peer group. So let's say three people over the course of 8 months all kind of say that you were kind of harsh to them or rude, or that there was something that just didn't sit well with them. This again is brought to your attention by a peer and said, hey, just so you know that this has now happened several times. This does separate you from your colleagues. I want you to think about it and think how you interact with people and things like that. Again, giving you the ability to self-correct and regulate kind of your own kind of impression that other people. Now, if this continues to happen, now this kind of takes on another level. This is now a guided intervention by authority. So unlike the previous ones where it's brought to your attention by a peer and you're given the chance to kind of correct it yourself, now if that hasn't worked several times, like I said, one time here and several times here, now kind of corrected action is kind of given to you. This is how we need you to fix this. And then if it continues to persist again, it then goes up here to disciplinary intervention. Like I said, the just culture algorithm on the right starts with human error, where these are mistakes, slips, and lapses. Purpose is on the top. This is sabotage, threat, sabotage, stealing things, using drugs, going into patients' records to gain information on them. That kind of sits at the top. Now, what scares most people, and obviously rightfully so, is the word termination that sits here. And I want to point out to you that there are very few things that get you to termination right off the bat, but there are some things that escalate these things immediately. Again, if you're showing up at work using cocaine and you're throwing screws in a patient's spine that aren't even screwed into anything, that are just sitting in the soft tissue, yeah, that's purpose. Sabotaging equipment, these are things that are going to get you terminated. If it is something egregious on professionalism, so threatening harm, putting your hands on someone, sexual harassment, disparaging someone's race, religion, ethnicity, again, threatening them either in person or by electronic means, that gets you kind of all the way to the top very immediately. Other than those things that are egregious, and they're not just egregious at Moffitt, they're egregious anywhere. Other than those things, the system is designed to continuously push you back down it, allowing you time and time again to be aware of something, giving you coaching, giving you opportunities to correct the behavior that you're engaged in that doesn't fit with our standards, kind of repeatedly over and over again. And then if you can't correct it on your own, designing the correction for you. And then if you still don't do it, then it kind of continues to escalate. And really, it is a climbing of the mountain to get there. Now, the mountain is invisible, right? Because you don't know what someone is going through. For example, I'm talking to you right now. You have no idea if I've had documented verbal counseling, first written counseling. That's between me and the organization. But this is the process that the organization does for everybody. Again, it's not always visible, but this is how it works. And this is how it aligns with, again, just culture and promoting and our professionalism. Someone leaving or separating from the organization is not beneficial to anyone. It's not beneficial to the person who's leaving, obviously. It's not beneficial to the organization, which has invested time, energy in bringing them on board and getting them trained and having them know in their experience and expertise, giving it to both the organization and its patients. So that's why it is, in fact, designed like this. All of this is done with the goal of maintaining a professional culture and keeping everyone accountable to each other. Now, on both sides of this is kind of this offering of grace. So again, single concern is not a big deal. That's not going to get you in trouble unless it's, again, something egregious. You're allowed to make mistakes and have rough days and be unprofessional from time to time. Expecting all of us to be professional every single day of the week, it's just not going to happen. The same with here. Make a mistake, you give TXA intravenously instead of giving it to the surgeon to give into the joint. That's not going to get you fired. It's not going to get you in trouble. These are the offerings of grace. So if we look at kind of the just culture side and talk about that IV case that we mentioned earlier, where is it? Is it just someone made a mistake? Is it at risk or reckless behavior? And that's why we kind of move away from this five rights, because if you're one of those hardliners on five rights, you could say, the person who gave it did not abide by the five rights. That's reckless behavior. I don't think that it is. And I work my hardest in convincing everybody here that it's not. This is kind of human error. The bag was designed inappropriately. Now, if it happened to you and you gave it intravenously and a week later you give it intravenously again and you despite the fact that we've changed the bag and how it looks and how it's distributed to the nurses to kind of keep it from making its way to the anesthesia provider, you continue to do it again. Now it kind of climbs the thing, and that there are more repercussions for it. But again, nothing that's going to get you kind of fired on the spot. And that's kind of what we want to do here. We want to move away from this hardcore just culture algorithm, which is retributive, which is you make a mistake and we figure out which one of these things apply and punish you, and we try and fix the system and move forward instead of with retrospective accountability, with prospective accountability. You've made the mistake, fine. We all make mistakes. How do we move forward from this so that we don't make the mistakes again? Now, grace, like I said, is something that's important on both sides of this, and that's where the devotion comes into play. It's offering people grace for making mistakes. That needs to be the way that we do things here. The standards side of it, the standards of that matrix I showed you earlier, is that there's not endless grace. So again, you're allowed to make mistakes, that's fine, but you can't make endless mistakes all the time and not take the work that we do here and the work that you do seriously. So what we've done is we actually took this model and we brought it back to the people at Vanderbilt who attended this course. They loved it. They asked for a copy of it. In fact, one of them just reached out to me a week ago to see if he could share the copy of how we do things here. This has made its way through HR here, and they are supportive of it. Again, this is not meant to replace HR, to isolate them out, but kind of to focus on this community of how we're going to take care of things in our department in a way that aligns with Moffitt's greater policy, and they agreed that this, in fact, does. So this is something that we can move forward with. So I'm just going to end in 3 minutes. I'm going to be quiet now. If anyone has any questions about anything that we talked about, I'm happy to answer them either here or you can come find me. I'm here all day. Well, if no one has any questions, I'll accept stunned silence as a response. Like I said, I hope you have a great day. If you have any questions on this, please come find me, email me, text me, call me, drop by the office, find me in the hall. I'm happy to talk to you more about this. I hope you guys have a great day and a great weekend. Thank you.